Cool, so my name is Amanda, and I'm the lead nurse for East Kent Hospital's lead diabetes nurse, not lead nurse, because that would be really scary. I do diabetes, and I'm here with Vicki.
Yeah, so I'm a diabetes specialist nurse working at Leicester Diabetes Centre. I have two roles. I'm involved in education and training, primarily primary care, healthcare professionals, and then I work clinically 1 day a week as a community DSN, soon to be moving into general practice.
So I just do inpatients and pumps. So these are our disclosures. So we have a few diabetes facts and figures for you. Diabetes impacts 4.3 million people in the UK. 90% of those will be type 2 diabetes. But we do have about 8% of people will have type 1 diabetes, and 2% have the rarer form, sort of genetic, moly type diabetes. So those of you that are not diabetes specialists, type 2 diabetes is more your insulin resistance, lifestyle kind of diabetes, whereas type 1 diabetes is an autoimmune condition where the body kind of attacks the pancreas and you don't make any more insulin. So if we do the next one.
Yeah, so those figures from that slide was a new report out by Diabetes UK a couple of months ago. And it has looked at new cases as well, so in the last kind of quaff year, I think that'll be from the National Diabetes Audit data, new cases of diabetes, 150,000. We know that there are lots of people out there as well at risk of developing type 2 diabetes, so 13.6 million, and of that 2.5 million nearly are at high risk, and that's based on HbA1c levels, so they're categorised into sort of low, medium and high risk. We still think that there's about 850,000 people out there with type 2 diabetes that don't yet know that they have it. And we are finding that it's becoming increasingly common in people under the age of 40. So we're now calling that young onset type 2 diabetes. And it appears to be, there seems to be more of an aggressive sort of
Genotype.
Yeah, genotype. And obviously people are going to be living with that condition for a lot longer. Gone are the days where it was sort of a condition of people over the age of 40 or older age. We are now seeing it in much younger people. Current statistics say that 64% of adults in the UK are living with obesity or are overweight, and obviously this does then have an impact on developing new cases of type 2 diabetes. And there's still lots of evidence out there to show that in some people, or many people, dietary changes, increasing physical activity and weight loss can actually reduce the risk of type 2 diabetes by about 50%. So I think we all know that anyway. It's just, I know, we are very medical focused with a lot of our diabetes treatments, but it's kind of just coming back to basics really to see how we can prevent those cases.
So NICE guidance has been updated recently, so there's been a massive increase in access to technology. So I don't know if you've seen adverts on the telly for Freestyle Libre. Many people are now getting access to that with type 1 and type 2 diabetes. Pretty much all people with type 1 diabetes will have some sort of CGM or flash glucose monitoring, so either a Libre or a Dexcom 1 or something like that. So people with type 2 diabetes, we're now starting to get access. So it would be those people that are on insulin mainly, but more and more people are using it. We have this thing called a hybrid closed loop. So this is an insulin pump connected to a continuous glucose monitor, and the insulin, either you get more insulin or less insulin depending on what your blood sugar is, and it helps that person with type 1 diabetes to kind of keep their glucose levels in a target range. It's not perfect. People still have to bolus for meals, they still have to bolus when things are out of range, and they still have to do things if they're going to do exercise and stuff like that, but there's a lot more access to those types of devices, and this year we're hoping to see in about October time a NICE guidance about accessing hybrid closed loop, who can get that. So 84% of people using technology say it helps them manage their condition, and 79% said it improves their well-being. But it is a little bit of a postcode lottery at the moment, because we're waiting for this hybrid closed loop NICE guidance. Some areas are just doing it, and some areas are not doing it because they're obviously waiting for the guidance. And money's a big issue. We don't, you know, we're not allowed to do things without it coming through NICE a lot of the time because, you know, we have to make sure it's cost effective. We live in an NHS firms healthcare system, and yeah, everything has to be cost effective. So they're very expensive. Some of these hybrid closed loop systems, about £4,000 for a pump, and then you've got the consumables on top of that each month. People are having cannulas, sensors, syringes, all of that kind of stuff. So very expensive, but cost effectiveness, it improves people's lives. It massively reduces their complications and keeps their time in range massively improved.
So we've talked about the associations, haven't we, between you know, cardiovascular disease, renal disease, and diabetes. So we've known for a long, long time, you know, looking back from some of the landmark diabetes trials, that early diagnosis and intensive glucose management, not just glucose, but we're talking about glucose at the moment, is really important, and that's the legacy effect shows us that early intervention, good glucose management in the early days following diagnosis, we know that reduces the risk of complications in the long term. And that really is so important, particularly now if we're getting lots of younger people being diagnosed with type 2 diabetes. So that's really where the focus needs to be. And we know, unfortunately, and I'm focusing on type 2 diabetes here, sorry, that is my sort of specialty, complications can actually begin before diagnosis. I think now we are diagnosing people a lot earlier. It used to be sort of people could have diabetes for up to 10 years, type 2 diabetes, before diagnosis, but obviously in that time, complications can already occur before somebody even knows that they actually have type 2 diabetes. And these are some of the updated statistics from the Diabetes UK report. You know, many amputations every week. We've talked about strokes, heart attacks, and cases of heart failure, and that's happening every week. So that preventative medicine is certainly something that really needs to be in focus. We've talked a lot about the physical kind of complications of diabetes, but we also know that people with all types of diabetes are twice as likely to suffer from mental health issues, so depression and psychological well-being. So again, that's something that we really struggle with, isn't it, in diabetes, having access to those specialists and support.
Then we talk about money, it always comes back down to money. Right, we're nearly running out of time, so I've got to be really quickly now. Okay, so diabetes in the NHS, this statistic is not new, £10 billion a year on diabetes, about 10% of the entire NHS budget, and most of that's on complications like heart failure, renal disease, all of those kind of conditions. So we currently have a real issue at the moment with GLP-1 receptor agonists. I don't know if people are aware of this kind of medication. So those types of medication, we're using those to kind of help prevent some of these conditions. So it's not, you know, they've got cardiovascular protective properties, and now we can't get hold of it at all. So people are not going to have that cardiovascular protective quality and may end up on insulin, which then kind of leads to hypos, weight gain, and we're kind of going back in time a little bit at the moment. So they're kind of the struggles that we're having at the moment.
So after COVID, recovery and restoration, not only for diabetes services, but you know, all healthcare services really. This was a survey again done by Diabetes UK, and you know, only not even 50% of people are receiving all their kind of 8 care processes out of primary care, unfortunately. You know, nearly 50% have said that they had difficulties managing their condition, and if you think about how long somebody with diabetes spends with a healthcare professional every year, it's probably about 3 hours at the absolute maximum, so they've got the rest of that time to self-manage their condition themselves. People have had trouble accessing some of their specialist teams. People have had trouble trying to access psychological support, which we already mentioned. And there have been incidences, is it 1 in 10 people have had elective surgery delayed because of their glucose levels not being at an appropriate level. And then there was a lot of information recently about stigma. So some people are not going to their appointments because of stigma that they're actually receiving from healthcare professionals with, you know, with their help them, and we want them to come and see us because that's what we should be doing. So stigma is a big thing, and I guess it depends. You might see that if you're avid Twitter users, sometimes you do see a lot of information out there about stigma, which definitely needs to change.
So diabetes specialist nurses, here we are, save the day. We reduce length of stay, we reduce drug errors, we reduce, all those kind of errors that happen in hospitals and in the community. So if you want to have a big read of this lovely document, it will tell you all about the impact of specialist nurses on inpatient care, which kind of shows your work, proves our work.
You will see a familiar name on there, Professor Alabraba. So yeah, we play a crucial role in lots of things: education, self-management, professional education, and that's a large part of my role as well. Medication safety, psychological interventions, and reduction in inpatient harms. But what we don't have a lot of information or data on is our community kind of diabetes nursing colleagues, which I have one. There's lots of data, isn't there, for inpatient diabetes nurse and outcomes, but there is little guidance on community and how many community specialist nurses we might need for a certain population.
I think it's very difficult because different community nurses teams do different things, whereas inpatients is pretty standard, so it's easier to calculate the community. So we have workforce challenges. This is quite a miserable slide to end on, sorry. But lots of our workforce are going to retire, as Alison said, are banded into equal care. I've seen some diabetes specialist nurses on band 5, which is just not acceptable. That's newly qualified band 5, isn't it? Why are people accepting that? And there's no real training pathway, clear pathway as to how do you become a diabetes specialist nurse. As we get asked this all the time, and it's kind of people just get a job and learn on the job, and there's no right, if you want to be a diabetes nurse, right, you need to go here, you need to do this is how you get there. And people have different issues with getting study leave. Some people will get loads of study leave, some people will get no study leave, and then end up doing things like this in their annual leave. And we're competing with primary care as well because they're not on the agenda for change. Sometimes they'll pay more, sometimes they won't in Media's instance, but sometimes you can earn more as a practice nurse than you can as a diabetes specialist nurse, which is fine, but it means we can't get the nurses into specialism because they can earn more doing a practice nurse role.